Good morning, and welcome to the Johns Hopkins briefing, focused today on the global monkeypox outbreak. I'm Lainie Rutkow, a professor at the Bloomberg School of Public Health and Vice Provost for Interdisciplinary Initiatives at Johns Hopkins University. I'll be moderating today's briefing. The first human case of monkeypox was detected over 50 years ago in Central Africa, and the virus is endemic in that region as well as West Africa. This year's outbreaks of the disease are novel because, in the words of the World Health Organization, this is the first time that many monkeypox cases and clusters have been reported concurrently in non-endemic and endemic countries in widely disparate geographical areas. Between the beginning of 2022 and today, 89 member countries of the World Health Organization have reported more than 31,000 laboratory-confirmed cases of monkeypox, as well as 12 deaths. On July 23rd, the Director General of the WHO declared that global monkeypox outbreak is a public health emergency of international concern. By doing so, the WHO alerted public health and healthcare systems around the world about the need to pay close attention to this outbreak, and the organization issued recommendations for WHO member countries. Here in the United States, as of August 10th, there have been over 9,000 confirmed monkeypox cases. Last week, the Biden administration declared a public health emergency and appointed a coordinator to lead the administration's response to the monkeypox outbreak. That followed emergency declarations made by 3 US states, California, Illinois, and New York, and several American cities. I'm grateful to the 4 Johns Hopkins experts taking part in today's briefing to discuss this evolving situation. Joining us today are Dr. Amesh Adalja, who is a senior scholar at the Johns Hopkins Center for Health Security, an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health, and an affiliate of the Johns Hopkins Center for Global Health. His work focuses on emerging infectious diseases, pandemic preparedness, and biosecurity. Today, Dr. Adalja will talk about how monkeypox spreads and ways to contain the outbreaks. Dr. Noreen Hynes is an associate professor in the Johns Hopkins School of Medicine, Division of Infectious Diseases, and is jointly appointed in the Bloomberg School of Public Health in the Departments of International Health, Environmental Health and Engineering, and Population, Family, and Reproductive Health. Dr. Hynes also serves as the Director for Research and Associate Medical Director of the Johns Hopkins Hospital Biocontainment Unit. Today, Dr. Hynes will talk about the prevention and treatment of monkeypox. Dr. Jason Farley is Endowed Professor of Nursing Leadership and Innovation at the Johns Hopkins School of Nursing, where he directs the Center for Infectious Disease and Nursing Innovation. Dr. Farley also serves as co-director, Clinical Core, at the Johns Hopkins Center for AIDS Research, and as a nurse practitioner in the Division of Infectious Diseases at Johns Hopkins Medicine. Today, Dr. Farley will discuss the social context for monkeypox and ways to reduce stigma around the outbreaks. Finally, Dr. Bill Moss is a professor in the Departments of Epidemiology, International Health, and Molecular Microbiology and Immunology at the Johns Hopkins Bloomberg School of Public Health. Dr. Moss also serves as Executive Director of the International Vaccine Access Center, Deputy Director at the Johns Hopkins Malaria Research Institute, and as the Vaccinology Lead for the Johns Hopkins Coronavirus Resource Center. He's a pediatrician with subspecialty training in infectious diseases. During today's briefing, Dr. Moss will talk about the availability and distribution of monkeypox vaccines. Before I turn to each of our panelists for their initial thoughts, I want to remind our audience that we'll be providing answers to your questions in real time today. So please submit your questions for our experts in the box that you see at the bottom of your screen. When you do so, if possible, please include your organizational affiliation. We're going to start by having each panelist provide brief overviews of key topics, and then we'll turn to Q&A. Amesh, I'll turn to you first. Can you explain how monkeypox spreads and talk about possible ways to contain the outbreak?
Sure. So thank you for that introduction. Thank you for attending this briefing. So what I'm going to do in the next couple of minutes is give you an overview of how monkeypox spreads, the different mechanisms it gets from person to person or it gets into humans. So there are several different ways. And I think if you go back historically and you read a textbook about monkeypox, they would say in the 1970s and 1980s, 3/4 of cases, for example, in the DRC occurred when people had exposure to some animal, some type of rodent, some type of squirrel. That's historically how we saw monkeypox get into humans. But soon after, we realized that it's not just all animal to human spillover events. That close person-to-person contact also is a mechanism for this virus to get from into people. And it can also involve things like linens or clothing that might have been worn by somebody that had monkeypox and had monkeypox lesions. That's primarily what we've seen. And eventually that 3/4 being related to animals is now probably 3/4 related to person-to-person spread. One of the things that comes up is also respiratory spread. And theoretically, there have been demonstrations of respiratory spread of this virus when people are in close contact with each other, but sometimes it's very hard to separate what's from close skin-to-skin contact versus what's a respiratory droplet going from one person to another. Well, one thing I think is important to understand how easily it spreads is that it's not, when you look at the household attack rates, it doesn't seem to be spreading very easily. So for example, if you take a disease like measles, the number of people in a household that will get measles if one person has it is basically 100%. For COVID, maybe 20% to 40%, depending upon which variant. But when you look at monkeypox in households, it doesn't seem to spread anywhere near that. Sometimes you look at quarters that are single digits, which tells me that it's not very efficient at spreading outside of very close contact with people. And I think this is an important point that I sometimes see missing in a little bit of the press coverage is just because there's multiple mechanisms for a virus to get from person to person doesn't mean it's using all of those. And when you're thinking about control, when you're thinking about understanding the epidemiology, it's really important to focus on what is the main way, what's driving the transmission. And I think there, with this monkeypox outbreak, it's really close skin-to-skin contact, not so much all of those other routes. Even though they're possibilities, it's not what's driving the outbreak. And I think that's an important point to take home, is that just because there's a mechanism for it to get from person to person using some means, it doesn't mean that's what's actually happening on the ground. Another important thing to think about with transmission is going back to 2003 and the outbreak that was linked to prairie dogs in the Midwest. When you look at the cases there really wasn't transmission from person to person. From my understanding is every person that was infected at that time had some contact with an infected animal, had some exposure to an infected animal. And I think that's remarkable because there were several dozen cases. People weren't alert to monkeypox, and they were these are people handling animals, and all of them kind of were contained within people who had contact with those animals, which I think speaks to the fact that maybe that monkeypox is clearly less contagious than its other family member, smallpox. The other point I wanted to make about monkeypox and transmission is that it's not known to be contagious during its incubation period. When you think about what makes a pathogen be prolific, what makes a pathogen uncontrollable, contagiousness during the incubation period is a key factor. That's why SARS-CoV-2 was so hard to control. That's why the 2009 H1N1 pandemic spread throughout the world in a matter of months, because if something is contagious during its incubation period, it is very hard to intervene. And we don't seem to see that with monkeypox, just like we didn't see that with smallpox. And that's actually key to one of the reasons why smallpox could be eradicated. So now let's fast forward a little bit to transmission that we've seen more recently. And many of you probably have seen that NPR article about the outbreak beginning around 2017 in Nigeria, where at least one astute clinician was noticing different patterns. They were seeing person-to-person spread in individuals who had multiple sex partners, who had sex with commercial sex workers. And a lot of the lesions were in the genital area. So clearly there had been some understanding or some recognition that this virus could get into sexual networks and spread with that close contact. And I think it's important to use the word sexual network or that close contact, because it's not clear at this point, if monkeypox is behaving as a strict sexually transmitted infection, meaning is the virus being conveyed from one person to another in bodily fluids. There have been studies showing that viral DNA can be seen in those bodily fluids. And I think some of the symptoms like proctitis or inflammation kind of the anus and the rectal area suggest that there may be some strict sexual transmission going on, but I think that's still an open question. But it's really the close contact, I think, that's driving most of the spread, although there may be some component of sexual transmission that could be responsible for some of the symptoms. That's a hypothesis that I have. What I think happened with this outbreak and is interesting, because I think it's really about the virus being able to exploit network effects and close contacts between individuals and use amplification events like raves, where many people might have had multiple close contact with multiple partners, and some of them anonymous. And that allowed the virus to spread in a way that it really hadn't had the opportunity to do so before. It probably always had that potential. It just needed to get into a network like this. And I think it's interesting when you compare it, for example, to there's a meningococcal or meningitis outbreak going on amongst MSM in Florida that's been for some time. And what's happening there is the meningococcus bacteria is exploiting a network effect there and spreading amongst the population. So I think this is an example of how a virus or a pathogen can get into a community and exploit whatever effects that whatever connections there are and spread much wider than it ever had been able to before. And I think that to me, the monkeypox and the meningococcus outbreaks are interesting and have some parallels. Lastly, I just want to turn to some stuff about containment. When we think about how smallpox was eradicated off the planet, and I have the privilege to work at the Center for Health Security, which was founded by D.A. Henderson, the man who eradicated that virus from the planet, it was ring vaccination, meaning they didn't vaccinate everybody. They vaccinated close contacts of individuals, but what that relied on was very good contact tracing. So they knew who was actually exposed to a case. We quickly learned that that type of procedure did not work very well with monkeypox, because contact tracing was just inadequate, because many people did not know who they were in contact with and who might have been exposed. So they quickly moved to going after the at-risk population. So anybody that maybe is a man who has sex with men, has multiple partners, goes to those types of events where they had seen spread. Those are the types of people that they were targeting with the vaccine. So the ring vaccination approach didn't work. And really, that's the containment here, is going to be getting vaccine into the at-risk group. And the problem is, as we all know, we don't have enough of that vaccine. This is a second-generation vaccine, Jynneos. They're talking about dose-sparing regimens now, which I'm sure people will have questions about. But there's not enough of it. And there's a different risk-benefit ratio than there was, for example, in 2003, when they used first-generation vaccines to contain the outbreak. There was Jynneos, people first generation vaccines. And here, I think there's an open question of, should we be using first generation vaccines to help contain this? Because there are some people that can take that vaccine. Not everybody, there are side effects there, and there's a different risk benefit calculation between monkeypox and smallpox and the fact that Jynneos exists. But I think this is something that should be discussed, at least, and offered to individuals who are willing to take it, who are counseled about the side effects. But really, in lieu of the vaccination, we have to think about harm reduction. And we do harm reduction from many infectious diseases. And I think it's really important to give people tools to tell them that having a new sexual partner right now is something that's a risk factor for monkeypox, and maybe thinking about decreasing the number of partners temporarily until you're vaccinated or immune, or making sure you exchange information with people so that makes contact tracing easier. All of that's going to be really important. The CDC has put some clips out about harm reduction. And I think that's something that really is going to be key until we get enough vaccine into the population. So that's what I have right now. Hopefully that was interesting, and I'm happy to take your questions at the end.
Thanks so much, Amesh. Noreen, I'm going to turn to you now. Can you give us an overview of what we know about ways to prevent and treat monkeypox?
Well, thanks very much. It's a pleasure to be here. Amesh has given a tremendous background for this lead-in. And as you're going to hear, he's already touched on many of the aspects of control, prevention and control. And there are both non-pharmaceutical interventions, that is, not having to take a drug or a vaccine, but also pharmaceutical interventions. And I think that there are some important things for us to think about that have already been highlighted. The question is everyone at risk? I get many calls and many patients ask me, do I need this? I'm afraid of getting this. And so, of course, that gets into wanting to ask the question, who is at risk and who should we be preventing this in? And again, you're going to hear from Jason, who will talk about the stigmatizing effects that have come out since the communication that well over 95% of reported cases or identified laboratory confirmed cases have been in a specific group of people. So I think that over time, I'm just going to cover just a big highlight of saying everyone who gets monkeypox does not need to be treated with an antiviral, which we do have some, and doesn't necessarily need to and should not necessarily receive a vaccine. So there are ways certainly to avoid monkeypox if you know that you potentially are exposed to someone who has had monkeypox or might be at risk for getting monkeypox. One of the other things that we forget about monkeypox, and we also tended to forget a little bit about smallpox, but the first human monkeypox cases were actually found during the smallpox eradication program that, as you heard, D.A. Henderson led with a huge international team of folks. And although we knew about monkeypox occurring in non-human primates that were used for experiments in various places since 1958, we didn't see it in humans until 1970. And that was done in what was then called Zaire, which is now the Democratic Republic of Congo, or DRC. But the thing that they did find out as they investigated closely, there were actually asymptomatic cases of monkeypox occurring in people who usually had already been vaccinated against smallpox, but also individuals who had never been vaccinated against smallpox. And we're seeing some reflection that this might be true in the current large international outbreak because of reports from Europe in which retrospective analysis of samples that were collected for gonorrhea and chlamydia testing from throat and rectal cultures have actually been found to have monkeypox virus in individuals who did not go on to develop monkeypox. So that means if you're thinking you have a contact who has monkeypox and therefore you want to be careful, you also have to be aware that there could be people who are asymptomatic and never going to manifest the disease, although it's a small percentage. So one has to think, as was previously brought up by the previous speaker, of thinking maybe I'm going to decrease my sexual contacts. I'm going to make sure that I'm always using latex condoms, dental dams, and maybe staying more covered, my skin more covered during a sexual encounter, but any skin to skin encounter, hugging someone, etc. But the other thing we also know is from both smallpox and monkeypox, we know that you have high levels of the virus in your oral secretions before you have any symptoms. That is, during the incubation period. Many people do. And we're trying to understand what role that has in the transmission via the respiratory route because of kissing, hugging, getting close to someone's mouth while they're talking, similar to what can happen with tuberculosis when you're close to someone. So all of this remains unknown. But as pointed out, it is certainly not infectious the way measles is if a group is unvaccinated, because measles is like an aerosol that stays behind for 20, 30 minutes even after an infected person leaves the room. So, and as pointed out, we're not sure how the transmission goes on in a household, for example. That's important because it's all part of prevention. So if someone is living in a household, how do you isolate from them? How do you interact with them? What do you do with your pets? Because as we know, animals can be infected. As a matter of fact, monkeypox originally is a zoonotic infection. That is something transmitted from animals to humans, and now we're in the human to human transmission cycle. So there's the prevention, non-pharmaceutical interventions, and these run an array in a household, in a congregate living space, such as a school, a prison, a daycare center. All of these you have to take into the consideration who is there, what are the activities being done, how much time are they sharing space. WHO has said probably you should try to keep it under 4 hours of sharing space, but sometimes that is not necessarily possible. So those are non-pharmaceutical type interventions. Then we have pharmaceutical interventions. So even if someone is sick, they or actually has monkeypox, they don't necessarily need to receive an antiviral, because particularly the strain that's circulating in the US and worldwide outside of the endemic area is something that is usually mild, has, as you see, a very low case fatality rate. And although one could say, I want to decrease infectiousness to others, until we have enough antivirals to be able to actively do that, we probably are not going to do that in someone who can stay quarantined. But someone who needs to be in a congregate living space, we might be more likely to use one of the 3 antivirals that we have. The one that people hear the most about is tecovirimat or TPOXX, but there are others available as well. And then there are vaccines that have been alluded to by Amesh, and we have a live but non-replicating vaccine, MVA Bavarian Nordic, also called by its brand names Jynneos. And then we also have a live replicating smallpox vaccine, ACAM 2000. MVA Bavarian Nordic was originally created or contracted to be created by the Department of Health and Human Services as an alternate vaccine against smallpox in the event of a smallpox bioterrorist event, to be able to give this vaccine to individuals who should not receive the live replicating vaccine, particularly people who are immunocompromised, or the many, many people who have things like eczema, which can be problematic if you get the live replicating vaccine. So we do have vaccines, but for the non-replicating, the Jynneos vaccine, we currently don't have enough. And yesterday, the FDA announced that they're going to permit what's called fractional dosing for the doses to be cut, getting 5 doses out of 1 usual dose, and there'll still be 2 doses that you get. So more that we'll learn about that. And yes, there is the ACAM 2000 that we might have to take out, understanding it's a much more reactogenic vaccine with a lot more side effects. So I think before going into great detail, I think we should hear from the other 2 speakers, and then I know that many of you who are listening will have many questions, which we're going to be very happy to try to answer for you.
Thanks very much, Noreen. Jason, turning to you now. Thus far, the vast majority of cases in the monkeypox outbreak have been among men who have sex with men, but we know that transmission is certainly not limited to that group. Many public health experts are concerned about the dangers of stigma and discrimination in relation to the outbreak. Can you talk about the social context for monkeypox and ways to reduce stigma around the outbreak?
Yes, well, certainly. Thank you, Lainie. Hello, everyone. Good morning and good evening from Durban, South Africa, where I'm presently here working on some tuberculosis and HIV adherence research to other very stigmatized diseases globally. And we're going to come back to that as I end this part of the discussion related to stigma and what we have learned over the years in the HIV response. But before leaving for South Africa, I diagnosed my first case of a patient with monkeypox and have subsequently reviewed multiple cases both in our clinic and with colleagues around the country, including in New York City. And we are learning a lot of just valuable information and sharing these lessons as best we can with one another. But one thing continually seems to come up case after case after case, and that is this overwhelming sense of the impact of the diagnosis of monkeypox and living with this infection has on the individuals being diagnosed and experiencing considerable symptoms. So when I think about being asked to share what the impact of stigma is on people with monkeypox, I really want to center that voice, the patient's voice here. For those of you who may not be aware, stigma is defined as a deeply held, discrediting belief of being less than others. And you could see how that could be applied in the circumstances of many infectious diseases, but in particular with monkeypox. So with this particular illness, we've seen, and from my personal, both in my patients as well as in my discussions with colleagues, stigma presenting itself in a variety of different ways. The first is the outward physical manifestations of the illness lead to the potential for undiagnosed or unintentional disclosure by strangers. So the individual can look at another person, see that they have monkeypox, and exhibit symptoms of outright stigma directed at the individual who is experiencing this. So this can occur anytime a patient's asked to come into clinic with lesions that may be affecting their outward appearance. Labeling the outbreak, as has been mentioned by Amesh, the labeling of the outbreak as a disease among gay, bisexual, and other men who have sex with men is certainly both necessary from a harm reduction perspective, but also a stigmatizing message at the same time. Historically, this has not been a disease associated with the gay community, and as Amesh mentioned, the importance here is that it has taken the opportunity and the vulnerability of social networks to establish itself in the current outbreak, which is different than the prior outbreaks of this infection. Finally, the limited access to diagnosis, prevention, and treatment has resulted in those currently most at risk feeling forgotten, undervalued, and mistreated. Now let's put all this together and take, for example, my patient, mid-30s, well engaged in HIV clinical care for many years, virally suppressed, doing well, doing everything one needs to do from a harm reduction perspective to ensure HIV is not transmitted from one person to another. We call that the uninfectious equals undetectable equals uninfectious campaign, or U equals U. Now, but as a gay man, he is not out to his employer, many of his family members. And so that this diagnosis of monkeypox meant contact notification of friends, family, and sexual partners within his network, contact investigations, including his place of employment, as well as concerns about needing to be seen in public, even to come to clinic to receive a diagnosis because of outward appearing pox. So for him, we were able to access treatment relatively quickly within 4 days, which quickly began to resolve his lesions. However, his fear really intensified when we began to discuss the recommendations around how long to remain in isolation. The fear of disclosure of monkeypox to his employer, potentially leading to his outing as a gay man, was a real and present danger for him. But that was quickly given way for the fear of loss of employment when it was described that he needed to isolate until all lesions had crusted and healed and new skin had formed. And that may be anywhere from an individual not taking therapy, 3 to 4 weeks, to someone with therapy, and we're estimating, 2-ish weeks, although the exact duration is not known. So for too many people currently at risk of monkeypox infection, they continue to face limited access to prevention, treatment, and sex-positive harm reduction strategies. This fuels the dehumanization of a community who are fundamentally pro-science, pro-harm reduction, pro-vaccine, and pleading, in all honesty, for access to prevention and care services. Now, this harkens clearly back 40 years to the beginning of the AIDS epidemic, when the media and the scientific community and the world jumped on the gay community, the men who have sex with men community, as pariahs, the people causing AIDS. I'm hearing lots of messaging right now around with that similar tone. Now, 40 years in hindsight, we clearly know that HIV was circulating among heterosexual individuals for decades before we identified it in the gay population. We know historically that monkeypox outbreaks are not centered within the gay community. We are learning a lot more about the potential for transmission and whether or not there is direct sexual transmission, and what this new phenotype looks like from the 2017 Nigeria outbreak, that it began kind of the confluence of events leading us to today. And so what we need to think about is, how do we avoid the mistakes of the past? How do we learn the appropriate lessons from harm reduction and public health messaging and miscommunication that we all just lived through with COVID-19? And how can we center the patient and the patient's response in our response to our current monkeypox outbreak? Thank you.
Thanks very much, Jason. Turning now to our final speaker. Bill, we've heard a bit about vaccines already during these overviews. Can you please fill in any gaps for us about availability and distribution of monkeypox vaccines?
Yes, thank you, Lainie, and greeting to all of our viewers. As Amesh and Noreen have said, we have available here in the United States 2 vaccines that we can use against monkeypox. One, the ACAM 2000, which, as Noreen said, is a replication competent vaccinia virus that can only be used under an investigational new drug protocol for monkeypox. It's approved for smallpox. And as noted, that vaccine has a number of serious side effects associated with it. There may be, as Amesh said, a role for that vaccine going forward in responding to the monkeypox outbreaks. But most of the focus has been on the Jynneos vaccine, which is based on what's called a modified vaccinia ankara strain vaccine, which is not replication competent. Through serial passages, a number of mutations and actually gene deletions have been evolved in that virus so that it doesn't replicate in mammalian cells, and so that can be safely administered even to immunocompromised individuals. So, Lainie, I'm going to use a simple framework that you've heard me talk about with regard to COVID-19 vaccines that I call the 4 Ds: doses, delivery, demand, and data, that are really essential to a successful and effective vaccine rollout. I'm actually going to defer talking about the doses to the end, as that's where all the action is, and just make a few brief remarks about delivery, demand, and data. Once doses are available, we obviously need mechanisms to get those doses into eligible populations. Until Monday, the only eligible populations were those older than 18 years of age. The FDA issued an emergency use authorization for Jynneos vaccine in individuals younger than 18 years of age just this past Monday. And right now, given the vaccine supply shortage, the Jynneos vaccine is recommended for post-exposure prophylaxis, or what's called expanded post-exposure prophylaxis, for individuals with known or presumed exposure to someone with monkeypox, or with behaviors or experiences that put them at risk. Currently, it's not widely recommended that these vaccines be used, or the Jynneos vaccine be used, as what's called pre-exposure prophylaxis, although the CDC guidelines do say that this can be considered. And we may see that more wider use going forward as vaccine supply shortages are remedied. On the demand side, we have very high demand right now, but we do need to ensure going forward, particularly among those most vulnerable groups and groups with suspicion of either vaccines or the government, that demand remains high as vaccine supplies improve. And lastly, we need good data going forward. We need to be able to know how many individuals have been vaccinated with 1 or 2 doses. And I'll say this is really our opportunity to learn about the effectiveness of these vaccines against monkeypox. We really have very limited data, both with the subcutaneous administration and particularly with the intradermal administration that I'll talk about. So this is really our opportunity to make, through observational studies, to learn a lot more about the effectiveness of these vaccines and the associated side effects. The big issue has been the doses available. The U.S. government is currently distributing about 1.1 million doses, but some experts estimate that we need at least 3.5 million doses, and that need may expand as transmission increases. The way the U.S. government allocates doses is based on the number of cases within a particular jurisdiction, as well as the number of at-risk individuals. And these allocations are taking place through right now 3 waves. The first wave started on July 29th, where jurisdictions can get 40% of their full allocation. And then throughout this month through August 15th and then the end of August, the remaining 60% will be allocated to these jurisdictions. We expect the next delivery of about 500,000 doses to happen in October. And then not until next year are we really expecting a large supply of vaccine, over 5 million doses. Now, there certainly have been missteps along the way. At one point, the U.S. government had about 20 million doses of the Jynneos vaccines, but those vaccines expired. Those were stored in the national stockpile. There were delays in getting the 1.1 million doses that are currently being allocated by the U.S. government, delays in requesting these from the manufacturer of Bavaria Nordic in Denmark. And then also delays in additional orders of the 5.5 million. The U.S. government has invested more than $1 billion in this vaccine, owns reportedly about 16.5 million doses, but those doses were stored in bulk, not in the vaccine vials that we need in order to distribute these to the points of administration. And that's why the delays in these orders are why we're not going to get that 5 million doses until next year. So what are the solutions going forward? The U.S. government is looking to contract another firm that can actually do what's called the fill and finish, taking the bulk vaccine and bottling it, capping it and labeling it. That will expedite the availability of additional vaccines. There has been, in some jurisdictions, including Washington and New York, delays or proposals or actual implementation of delayed second dose. There is some concern about this because although we don't have great data, it's really that second dose that really boosts the neutralizing antibody levels. It's not felt that full immune protection comes until 2 weeks after that second dose. And there's particularly concern about those people living with HIV who may be immunocompromised, where by delaying that second dose, you're really putting them at risk. And so the biggest news lately has been this fractionated intradermal dosing. On this past Monday, the FDA issued an emergency use authorization for the use of intradermal injection, which is 1/5 of the standard subcutaneous dose for people 18 years or older. There is a biologic rationale for a lower dose of a vaccine administered intradermally because of the high abundance of immune reactive cells or antigen presenting cells in the dermis. And there's also historical examples of using fractionated intradermal dosing for yellow fever, inactivated polio vaccine, rabies vaccine, and meningococcal vaccine. So we have a fair amount of experience with this. And there is evidence. It's one study from a study published in 2015 in the journal Vaccine that showed similar levels of neutralizing antibodies with modified vaccinia Ankara vaccine when it's administered intradermally compared to when it's administered subcutaneously. There are some more technical or operational challenges to intradermal injection, but I don't think this is a major obstacle. And there are some technologies like adapters, needle adapters that can be used for and to facilitate intradermal injection. So just in closing, I just want to reiterate, as other panelists have said, that vaccines are only one tool in our toolbox. There are other preventive measures that can be taken. We also have to very clearly state what our goal of our vaccination program is. It's quite different than with COVID-19, where the primary goal was preventing severe disease, hospitalization, and death. We don't see that. We're not seeing that with the current monkeypox outbreak. We really want to prevent infection. And then lastly, the duration of immunity is not known. And so if this virus is here to stay with us for a longer term, we may need to think about booster doses down the line. Thank you, Lainie.
Thanks very much, Bill. And I want to thank everyone who's been submitting questions. There are a whole lot coming in, so we're going to move right into Q&A now. And Bill, I'm going to stick with you and batch a lot of questions coming in from folks who received a smallpox vaccination at some point in their lives. So going right back to durability, if someone received a smallpox vaccination, what does that mean relative to monkeypox?
Yes. So there's not, despite the fact that we're using vaccines designed for smallpox, there's not actually a whole lot of evidence around the protective efficacy of smallpox vaccines against monkeypox, although we know that there's a lot of cross-immunity with the different orthopox viruses. One of the studies is from the early 1980s in the Democratic Republic of Congo, where they showed that individuals who had been previously vaccinated against smallpox had protection against monkeypox. That said, smallpox vaccination was ceased 50 years ago here in the United States. And although the duration of protection following smallpox vaccination is not lifelong, it's a function of how many doses an individual received and whether they had any boosting due to exposure to natural smallpox. But so this is in the absence of good evidence, but my sense would be that there's probably little to no protection conferred by prior smallpox vaccination 50 years or ago or longer. There may be some protection against more severe disease, but again, we're not really seeing a lot of severe disease with this current monkeypox outbreak.
Thanks, Bill. Jason, question for you, and you can tell this is coming from a public that has spent 2.5 years living through a different pandemic. So the protections that have become part of our everyday lives, wearing masks, some folks are thinking back to the early days of COVID when they would wear gloves. How much does any of that help or apply for monkeypox?
Sure. So when we think about the transmission of monkeypox, we're talking about skin-to-skin contact. And there is also a theoretical risk of droplet transmission, meaning within 6 feet of individuals who cough, sing, or sneeze, similar to COVID, that 1.5 meters we all talked about, 6 feet. But also there is a theoretical concern around transmission within the environment. So shared surfaces, blankets, other things, linens, toilet seats are a theoretical concern. And again, like Amesh pointed out in his opening remarks, these don't seem to be coming to bear as much. Household transmission is much lower than we would have anticipated. I've seen the WHO has estimated the R0 somewhere around 1.4 to 1.8 at this point. And so we are not seeing major significant transmission within households. That being said, we are concerned about congregate settings, as Dr. Hynes mentioned in her remarks, and there are things that can be done for harm reduction in congregate settings. Obviously, early identification is instrumental and key. The second is cleaning surfaces that have been potentially exposed. And then removing or isolating individuals who have known monkeypox from others who before exposure occurs, if at all possible. This also needs to be done with the greatest amount of care. Obviously, in a dorm room or a congregate setting, the disclosure of the entire building about an individual's infection with monkeypox doesn't take very long and much effort to occur in that circumstance.
Thanks, Jason. Amesh, question for you about testing. Could you talk about what testing looks like right now in terms of availability for monkeypox? And again, you can tell these questions are coming from a public that has lived through COVID. Is it likely that with more accessible testing, we're going to learn that this is actually a larger outbreak than what we currently think?
I definitely think that we have not had enough tests to get a full picture of what the actual spread of this virus was. There may be cases that were missed, that were diagnosed as a sexually transmitted infection. We know that happened, for example, in Montreal. So a lot of the testing is going to be catching up and picking up cases that didn't come to notice. So we are going to see some more ascertainment of cases because testing has become more available. But I do think that testing has gotten better in the last several weeks than it was early on, where it was basically disastrous, where it was really restricted to CDC affiliated laboratories, which is not adequate in an infectious disease emergency. You can't expect clinicians to fill out paperwork, call a state health department to get the initials of somebody to put on a piece of paper that will then go with the specimen for the state health department to actually accept the specimen. That's a true story. That type of thing is not conducive to people wanting to test. And I think we really have to think about making testing much more distributed, even more so than it is right now. It's in commercial labs, some university labs are doing it, but this technically should be something that is at point of care, that clinics where individuals may be presenting for care can be tested pretty quickly. And we are limited because this is a test that requires you to swab skin specimens, and they may not be the first symptoms individuals get. So we need to think about, can we do saliva testing? Can we do other ways of testing for this so that people can know their status earlier? There's some technological hurdles there, but testing has, I think, just like it was with COVID-19, become a major barrier to getting a handle on an outbreak.
Thanks, Amesh. Jason, next question for you, and it concerns travel. So I'm sending it to you since you mentioned that you're coming to us from South Africa. What do we know about potential for monkeypox exposure and travel? How concerned should folks be? We have questions coming in both about domestic travel within the US as well as travel to other countries.
Yeah, historically, prior to the present outbreak, we would have talked about travel to endemic areas and regions of the world. Today, obviously, our recommendations have shifted. And so what we know right now is that your risk, your individual personal risk of coming in contact with an individual who might be have monkeypox is still relatively low. Again, we have limited data on how long monkeypox lives on environmental surfaces, and whether or not it's even replicating and transmissible virus is still an area of debate. And so right now, I would say the threshold for travel or your concern for travel related to monkeypox should have a very high threshold. You should feel free. You should travel. I don't think there are any current travel restrictions. Now, I will say, I have patients who are in my HIV prevention clinic using pre-exposure prophylaxis who are planning travel to endemic areas where currently are having a lot of cases among men who have sex with men. Do I caution them about harm reduction strategies while they are traveling? Absolutely. And I think that's just the important role we all need to be thinking about at this point.
Thanks, Jason. Several questions coming in about what best practices are for PPE for providers right now. Amesh and Jason, I know you have both seen a person with monkeypox. Could you speak to what PPE looks like in a practice setting?
So in general, we use basically airborne precautions, meaning that we put individuals, they wear a gown, they wear gloves, they wear an N95 type equivalent mask with eye protection. And ideally, if you have a room that is negative pressure, that's where you would put them in. Many hospitals, healthcare facilities are very attuned to this because it's very similar for COVID-19 patients. So it's not any different when you're seeing a COVID-19 patient than when you're seeing a monkeypox patient, even though I think that a lot of the airborne transmission of monkeypox, as I talked about earlier, or respiratory transmission, is probably not a major factor, and you probably don't necessarily need all of that, but that's the protocol that individuals are using. In the past, they would say, use it until smallpox was ruled out and then go to more contact precautions. But I think because of this outbreak and because of coming on the heels of COVID-19, people are sticking with airborne. And the fact is that now we have plentiful supply of the personal protective equipment that we didn't have in the early days of COVID. And that's usually how most hospitals and healthcare facilities are handling it.
Thanks, Amesh. Jason, anything to add from your clinical experience on this one?
Yeah, I would just, even though we are using an N95 particulate respirator, I still prefer to talk about this as contact and droplet. There is no evidence right now that this is an airborne infection, and sometimes that confuses people when we do use the word, and we're using airborne precautions because we're using an N95. But droplet transmission is our primary mode of transmission. The only other thing I would add, and I agree with everything that was said, is because we're ruling out patients who are oftentimes contacting healthcare facilities prior to their arrival, it means, at least in our setting, that healthcare workers are fully garbed, meeting the patient at the entrance to the clinic and escorting them to a dedicated clinical space. And I just want to remind everyone, if that's the protocol you're following, that has significant potential for stigma for the patient who is being walked through by a fully PPE'd healthcare worker through a clinic space. So just as an added reminder that even our actions to protect ourselves can result in a stigmatized community.
Thanks, Jason. Bill, a question for you about vaccines and supply chain. So you addressed this a bit in your opening remarks, but is there reason to be concerned given the more general supply chain challenges that we're seeing right now, supply chain concerns for monkeypox vaccine as we head into the fall?
Yes, well, I still think the major bottleneck is just having sufficient number of doses, and having those the fill and finish done, so that those vaccine doses that are available to the United States, we're able to get them to the providers so that those vaccines can be administered. This will also require, particularly with the intradermal injection, supply of the appropriate syringe and needle for that. And so there are other supply chain concerns. It's not just the actual vaccine doses in order to be able to expand access with the fractionated intradermal dosing.
Thanks, Bill. Jason, turning back to you, a lot of questions coming in about isolation and quarantine, and specifically, what does that look like for someone who either has a confirmed case of monkeypox or someone who has a known exposure?
Yes. Well, I would tell any clinic and providers listening that there are a very large list of steps recommended by the CDC. And when I handed my patient the list of things that they needed to think about, the patient felt a little overwhelmed by them. But breaking those down, doing one's best to isolate at home without contact with other individuals. So what that means is while someone's home, if you can avoid sharing as much common area as possible with loved ones, significant others, roommates, that is the recommendation. And that includes, trying to wipe down surfaces in shared space, trying to avoid sharing bathroom facilities and the like. Obviously, no shared soap or other kinds of forms that would have a skin-to-skin contact, although it's a theoretical, not a proven risk for transmission. And then when we talk about isolation, we do mean isolation within one's home environment, if that's all possible. Obviously, individuals who are experiencing homelessness and others have a different set of recommendations within congregate settings. But isolation at home until the lesions have completely healed. And without therapy, we do see that is a longer duration than with therapy. So in my mind, when I'm doing the calculus, I often add this patient may be low risk of extreme outcomes of monkeypox. However, if they have, a job that really tightly controls sick leave, for example, a 3-week vacation or 3-week time off work, we all wish it was a vacation. A 3-week time off work for monkeypox lesions to heal might be untenable for their particular employer. And so really thinking about ways in which we can use our scarce resources, but with the maximum amount of benefit, I think is extremely important as we try to block, both transmission as well as the social harms that come with isolation.
Thanks, Jason. Amesh, question for you about reinfection. What, if anything, do we know about reinfection for those who know that they've already had a monkeypox infection?
We don't have a lot of data on this, but I think we can sort of extrapolate from what we know about other orthopox infections, namely smallpox, that individuals who got infected with smallpox were protected from reinfection. That's one of the ways that we were able to eradicate it. And I think that there likely is a similar phenomenon that occurs with monkeypox, that people are not going to get reinfected, and definitely not immediately. There may be some time over several years that maybe somebody can get it reinfected, or that immunity wanes, or if they go on immunosuppression. But I think in general, we expect most people to not be susceptible to reinfection in the near term, which I think will be useful when it comes to thinking about the trajectory of this outbreak in non-endemic countries. But I think there's something that we need more data on, and maybe Dr. Moss has more to add on that as well.
Thanks, Amesh. Bill, would you like to jump in on this one?
Oh, I completely agree with Amesh. We don't have a lot of data on monkeypox on re-exposure, but I too would draw conclusions from, or inferences from, our experience with smallpox, and people did not get reinfected with smallpox.
Thanks very much, Bill. And given that we are soon coming up on the hour, I'm going to start to wrap up here. I'd like to thank our 4 panelists today, Amesh, Adalja, Noreen, Hynes, Jason Farley, and Bill Moss, for joining me. I'd also like to give a big thank you to everyone who attended this briefing, and especially to those who submitted questions for our experts to answer. A recording of this event will be made available on this website. Today's panelists, together with other faculty from throughout Johns Hopkins, will continue to analyze the evolving monkeypox outbreak. Thank you again for joining us today. Be well and stay safe.